one of the many gifts of COVID, reminding us we're on mute. Good morning, everyone, and welcome to Grand Rounds. I'm going to begin, as usual, with our land acknowledgement to remind us that Ottawa is built on unceded Algonquin and Anishinaabe territory. The peoples of the Algonquin and Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. And with that, I'm very pleased to welcome our speaker for this morning, well known to us all, especially through these past few years of COVID, Dr. Nisha Thampi, who is an infectious diseases pediatrician and associate professor in pediatrics at the University of Ottawa and CHEO. Dr. Thampi completed her medical degree in pediatrics residency at the University of Toronto, followed by fellowship in pediatric ID, also in Toronto at Sick Kids. She completed a master's in public health economics at the London School of Hygiene and Tropical Medicine in the UK in 2012. Following this, she completed a clinical research fellowship in antimicrobial stewardship in Toronto at Sinai Health Systems University Health Network. And then she came to CHEO. She joined Team CHEO in 2013 as a pediatric infectious diseases physician and medical director of the Infection Prevention and Control Program, well known to us as IPAC at CHEO. During COVID, she was absolutely instrumental in advising the hospital and region on pretty much all things COVID and in communicating on so many town halls with physicians, staff, and community. With her expertise and experience, she has been seconded to work with Public Health Ontario since 2021. And somewhere in all that, I didn't even realize this was happening, Nisha. She was able to complete the Regional Health Senior Leadership Program at Telfer School of Management in Ottawa and Rotman School of Management in Toronto in 2020. So I think she knows what she's talking about, and she's going to share her wisdom and experience with us today in her presentation entitled Navigating the Fall with a Crystal Ball, How Forecasting Modeling Was Used to Predict Volume and Acuity of the Fall 2022 Pediatric Respiratory Virus Surge at CHEO. Over to you, Nisha.
Thank you for the very kind introduction, Mona. It was a lot longer than what I had submitted. So good morning. You may recall emails from, sorry, I just want to make sure it's the white screen that's sharing, right? Yeah. So you may recall emails from the IMT about viral trends and forecasting updates through December and January. I was privileged to have had the chance to work with the team on providing these weekly updates to IMT. And I hope today to share the origin story and the impact of this work on the clinical operations and policymaking decision spaces. I also want to explore the potential for forecast modeling to improve access to acute clinical care while minimizing other service disruptions, and would really welcome your thoughts on next steps. So the objectives are threefold: understand the principles of modeling to forecast demands for hospital beds, review trends of the lab-confirmed respiratory viral infection admissions and patient acuity that we've seen over the last 4 years at CHEO, and demonstrate the utility of forecasting modeling on hospital resource planning for CHEO this year and in the future. So let's start with the why. Why are healthcare forecasting models important and relevant? Well, they seek to reduce the mismatch between bed capacity to bed demand. And the goal of reducing this mismatch is to improve patient flow, the corresponding clinical staffing requirements, and key performance indicators, which can include hospital access, wait times, quality of care, and rates of adverse events, which, as you know, with my IPAC hat on, are important, especially as they relate to hospital-associated infections and patient and staff or medical staff satisfaction. In terms of understanding how forecasting is done, it helps to know that there are multiple model types and structures that differ based on predictors that are inputted into the model. So prediction horizons can be daily, weekly, or monthly, depending on the hospital unit. There have been different models developed for predicting demands in various clinical areas, but there's an underlying recognition that all services are interconnected and cannot be assumed to be independent of each other. So predictors may include lengths of stay, seasonality, or specific viruses that contribute to, that drive surge patterns, clinical admissions, and census data. So the number of patients occupying specific inpatient beds at a specific period of time interval. So taking a step back to remember what it was like in fall 2022, the context at CHEO felt pretty unique. The hospital was persistently in a major surge from mid to late fall, and we had persistently strained human health resources. The incident management team system was formed at the end of October to support the hospital-wide response and liaise with regional and provincial partners to provide situational awareness and maintain local and provincial capacity to care for acutely ill pediatric patients through the viral respiratory surge period. An early priority that was identified by the IMT was a desire to understand the emerging and evolving trends and volumes. So not just emergency department visits and those visits requiring admissions, but also in inpatient medicine units and our PICU. By mid-November, we were seeing an earlier and steeper increase in RSV and influenza A related test positivity compared to pre-pandemic seasons. So the pre-pandemic years are blue, so before, the 1920 year, and purple, the 1819 year. So, you know, by mid-November, we got the sense that we were going to exceed those test positivity rates from previous years. And these are contributions from all Eastern Ontario hospitals. So it gave us a sense of what was happening in our community and not just in our pediatric population. The following trends were presented to IMT after that initial request, just looking at the volumes that we were seeing in those key clinical areas. So, you know, what we saw by mid-November were a stable number of ED visits compared to previous peak season periods, but we saw more kids needing admission up here. In the inpatient medicine and ICU, the volumes were increased during the recent period. And so that situational awareness led to three key questions. Number one, what is the current burden of admissions related to respiratory viral activity? And what is the true exceptionality of this period versus previous? Like, were these trends, you know, unprecedented truly, or were we an exhausted workforce and just unable to meet the demands that we could usually expect to see at this earlier on, but with the viral surge that we would usually get? Second question, what proportion of these patients required level 2 versus level 3 care? And these are, and I'll go through these definitions in a moment, but speaking to skill mix gaps that may be present in clinical areas or staffing pressures. And then finally, could we predict the peak and duration of this intense, early, unprecedented respiratory viral surge to help inform hospital resource planning? So I mentioned at the beginning that I was privileged to work with this team. Lynn, Liam, Connor. Lynn and Liam are from Bourne and provided a lot of the methodological and data analytics expertise. Connor is a QI advisor who was linked to IMT and specifically to our forecasting work. And then of course the data wizards, the CHEO business intelligence team, Justin, Casey, and Melanie. So what the CHEO BI team helped our team to do was to leverage Epic. So we went live, if you remember, in October 2017. And what we were interested in was looking at all patients at CHEO in terms of volume. So, and you saw that in the yellow graph, admissions to those 4 key areas. And then we looked at a subset of that earlier phase of data gathering, so what we called phase 2 data. And these were specifically children admitted with community-associated, lab-confirmed respiratory viral illnesses. So we excluded kids who had tests that were performed after 72 hours of admission. We we felt we were able to compare between the periods pre-pandemic and the present period because in terms of having no changes to testing indications for influenza A, B, or RSV. But we recognized an important limitation was in terms of our transfers. We were not able to capture all the transfers related to respiratory viral illnesses because they were only included if they tested positive at CHEO. And recognizing that not all COVID positive admissions had respiratory viral symptoms. So the other aspects of EPIC that we looked at were trends in levels of care intensity. So traditionally, we think of critical care in a unit-based approach, and that's how we defined level 3. So level 3 was the PICU, and then in this past season, or in this season, the PICU overflow areas. Level 2 is generally considered as a step-down unit. However, CHEO's model of care is a more distributive model of step-down, such that kids are not co-located on a unit, but still have additional care needs that require skilled nursing, respiratory therapy, physiotherapy, and medical supports. And a level 2 intervention would include receipt of high flow oxygen, non-invasive positive pressure ventilation, and the presence of a tracheostomy. By definition, a level 2 patient would be on the inpatient unit and not the PICU or PICU overflow units. And then level 1 were individuals who were on the inpatient units, not requiring level 2 supports as defined above. And then finally, we looked at ERLA data, so the Eastern Ontario Regional Lab data on test positivity rates. And again, that's looking at overall testing volumes, so not just the pediatric contributions, but also from the Ottawa Hospital, Queensway, Montfort, and other community hospitals in the Champlain region. And we looked at weekly test positivity for influenza and RSV as key drivers to the hospital activity during this period. So we presented to the IMT the data up to the end of November. And there were some striking features of the current wave that we could see even at that time. The earlier, steeper rise in volumes compared to pre-pandemic years. The current wave was driven largely by RSV, with increasing contribution from influenza A. We had more COVID-related admissions following the emergence of Omicron in blue, as you can see, with an initial peak in COVID-related viral activity in the winter, but it eventually stabilized through the spring and summer and actually didn't contribute significantly to the current surge in clinical volumes. The second question around levels of care, we looked at, we were concerned about, so we noted the increasing numbers of children and youth requiring higher care intensity. And so we went on to examine whether there were differences in the proportions of levels across the respiratory seasons. So what we see here, well, let me take a step back. It's actually hard to compare the 2017-18 year to subsequent years. People may remember that in December 2018, the hospital moved to a new standard of care to start all patients admitted with bronchiolitis on high flow oxygen by nasal cannula, and thereby assigned these patients a higher level of care intensity that may have, and then they may have been admitted to the PICU as was common practice at the time, or they may have been kept on the unit. But looking ahead, we saw no significant difference in proportion compared to the last pre-pandemic period of surge. But nonetheless, we saw 4 times the volume of level 2 patients at our peak this fall on the inpatient units. So the volumes certainly spoke to the intensity of the acuity that was felt on the units at the time. The last question from IMT was harder to answer. At that time, there was very little published on the experiences in Southern Hemisphere countries, and places in North America, in Canada and in North America and Europe were either having a surge period around the same time as ours or even a bit behind us. So, we went back to the drawing board and looked at different types of models as candidates. We looked at the ARIMA model, but that's based on past values of the same series, so it was pretty limiting. And we landed on the VARX model, which I will be very brief about because this is not a presentation on the methodological underpinnings of the forecasting models, but it allowed us to analyze changes and correlations between multiple time series variables using past data. And the X in VARX stands for exogenous inputs or variables, and it allowed for independent predictors to be included in the model. Our forecast horizon was 2 weeks, but we pulled the predicted data out to 2 months. The outcomes of interest were patient volumes in 4 clinical areas, as noted before, the PICU and related overflow units, inpatient medicine, and the ED. We recognized that ED visits requiring a bed were nested in the overall ED visits, and I've not focused on that model in today's presentation. We also looked at various predictors. So we were able to include influenza and RSV patterns into our model. We initially had incorporated SARS-CoV-2. However, when we went back to the model validation, which I'll explain in a moment, we found that it did not impact the prediction of volumes. So that was those values were taken out. We also knew that we needed the model to follow the shape of a curve. And again, we were watching other jurisdictions in the Northern Hemisphere with evolving curves like ours. And so that wasn't going to be helpful to model the shape. But we looked at jurisdictions in the Southern Hemisphere that had published their experiences. And these are related to influenza because in most parts of the world, RSV is not a reportable disease and not captured in national or even provincial surveillance systems. And important to note, what was not included in the model were staffing data and the impact of the additional bed capacity created in November 2022. So going to the different Southern Hemisphere countries' experiences, we knew very quickly that we were not in line with Chile's experience that was published in the MMWR sometime, I think in October, November. They had a blunted flu season compared to previous winters. We looked at South Africa, which had and we were interested in South Africa's experience because they had a biphasic flu season that lasted for a lengthy 30 weeks. So we were really hopeful that we wouldn't be in this in the circle of hell for 30 weeks, but at the same time, we didn't know what would be happening over the holiday period and whether we would have a biphasic flu season like we've had in the past that's driven by influenza B or other type of influenza A, against which our community had little immunity. In Australia, the early and steep increase in their influenza detections seemed to mirror our regional, provincial, and national experience. And so we used the curves from Australia and South Africa to inform our forecasting models. And it's interesting to note that the Children's Hospital Network in Australia conducted their own modeling to predict the number of children who would contract RSV, so not influenza, but RSV, and the number who would require hospitalization. And unfortunately, their lived experience was twice as bad as the worst modeling predicted. And this was in a presentation that they gave in late October to provincial stakeholders in Ontario. And hearing that and seeing these curves made it even more uncomfortable to see what was happening in our microcosm at CHEO. But when we looked at the viral trends by December 10th, we had actually seen influenza A test positivity on the downturn. We still had fairly high prevalence of RSV, and SARS-CoV-2 was pretty stable, if not on the lower side of what we have come to know about SARS-CoV-2 prevalence in our community. But we were heading into the holidays and could not be certain that this downturn would be sustained. And so we presented our forecasting model initially to the IMT in mid-December. At that time, we continued to see unprecedented volumes of admissions. Overall, that's the gray line, and admissions associated with respiratory viral illnesses, this peak. We presented 2 scenarios to IMT. And while we included RSV in the model, the pragmatic scenarios, as I said, were reflective of the influenza seasons in Australia, which is scenario A, and South Africa, scenario B. So scenario A was the rapid decline in RSV and influenza cases, similar to what was noted in Australia. The second scenario reflected a slower decline in RSV. This is for RSV. So this is scenario A, we would see a rapid decline. Scenario B, we'd see a slower decline. Similar to what had happened in South Africa with influenza, we would see a slower decline and a resurgence in February. So here's one of the initial forecasting models that we presented for inpatient medicine. And what you see here, depicted here, is the predicted volumes in orange and the uncertainty around those estimates in dark green and lighter green. The darker green bands represent less than 1 standard deviation, and the light green bands are 2 standard deviations. The volumes over the 2-week holiday period, which is bound by this line, were predicted to decrease from mid-December's clinical volumes. If RSV and influenza volumes dropped as quickly as they did in scenario A, we predicted that inpatient medicine volumes would drop faster as well compared to scenario B. And so we gave a summary every time we presented our forecasting models to the IMT. And for the sake of time, I'm just sharing the summary because we have more graphs to go through. But basically what we were seeing were declines in inpatient medicine, but an increase in PICU volumes and a stable number of ED visits through the holiday period. I will point out some important caveats to the forecasting work. One is that it was a high level of analysis of time series data on the ED, PICU, and inpatient medicine volumes. It took past trends into account when estimating future values, but there were likely external factors not taken into account beyond volumes of patients with respiratory viruses at CHEO. And I've already mentioned the staffing shortages that was not taken into account that may have defined capacity to admit differently than if we had just looked at beds and previous volumes. Forecasting beyond 2 to 3 weeks can be quite volatile, and so we cautioned that the data must be interpreted cautiously. So next, we wanted to see how well did the forecasting model perform for the validation. And so we fitted the model using data from 4 years before. So I said initially that we had looked at 5 years, but for census data, we were able to get those consistently from November of 2018 to present. So we held out 1 month. So we held back 1 month of data. That was November 13th to December 10th of last year, of that period. And we tested our predictions against actual values from November 13th to December 10th. So in terms of ED visits, this is what the validation looked like when we held out 1 month of data. The model performed well here. So again, orienting us to predicted data against the light blue actual data over the past month. All actual values fell well within the predicted 80% forecast interval. In the PICU, when we held out 1 month of data from November 12th, all values fell within 80% of predicted intervals. The model generally performed well for predicting inpatient medicine volumes, with almost all actual values falling within the predicted 80% forecast interval, and all values fell within 95% forecast intervals. However, What we can see here is that inpatient medicine volumes peaked sooner than predicted in the previous months, and we're on the downturn. Validation was done weekly to ensure the models performed well, i.e. we wanted to see that actual values were falling within the predicted 80% forecast interval or within one standard deviation. And so this is looking at the data from December 4th to 31st. So it would have been presented in the first week of January to IMT. And we noted that the models continue to perform well for ED and inpatient medicine, and with data closely aligned between actual numbers and predicted numbers. But I want to take note of the deviation in ICU volumes during this time, and I'll return to this shortly. Throughout this work, we wanted to ensure that the data were useful to IMT. And so we kept returning to the 3 questions asked of our team. So, the current burden, the level 2, level 3 burden, and the predictions for peak and duration of the surge. So looking at the first one, we received feedback throughout that it was validating for clinical and operational leaders to see that this was truly an exceptional surge period. So just orienting you, in peach is the current respiratory viral season. You can see where this is up to early January. But we were still, so we were seeing RSV volumes that were very different from what we would see at other times in January. But that was after having gone through this exceptionally intense period of admissions related to RSV and to influenza. As to the question regarding levels of care intensity, we saw changing demands among different age groups and an eventual overall reduction in volumes of children requiring level 2 supports. So looking at the left panel, which is by month, we saw about 4 times the volumes of level 2 patients at our peak month of clinical activity compared to previous peak season volumes. The right panel is for the current surveillance year, which is defined as the beginning of September to present. And that shows week-to-week variability in this surveillance period, stratified by age groups. And you can see that most contributions were kids aged less than 5 years. Similarly, we saw changing demands on level 3 supports or level 3 admissions. And so looking at the left panel, at our peak in November, we had nearly 3 times the volume of children admitted to the PICU with respiratory viral infections compared to previous peak periods. And on the right, we see more clearly the age group distributions to PICU volumes, again, for lab-confirmed viral respiratory infections, and consistent reduction in volumes coming out of the holiday period. But a reminder that we don't have staffing data to help us understand the impact of staffing capacity on these volumes. And this is an important consideration. So returning to the model, which predicted an ongoing increase in PICU volumes through the holiday period, so the orange line, we actually found that the actual data was very different. And we recognized here, like I said, we did not capture the increased staffing shortages that the PICU was facing heading into that first holiday period. However, clinical operational leaders noted that and recognized that there were low staff numbers in the next 2 weeks, so going into the holidays, especially in that first Christmas weekend. And the model was showing more patients were likely to require admission to the PICU or likely to be admitted to the PICU. And so there was a decision after that IMT to decant the PICU and to send patients to other centers in Ontario that were not as challenged with capacity heading into that specific Christmas weekend. And that's how the blue line of actual data went completely off course from the model, but the PICU managed to stay open to transfers from the units, from other units within CHEO and eventually to to other centers during this period. So when we look at overall impact of the trends and forecasting analyses, we were able to provide situational awareness to IMT by being able to analyze trends up to the week before and being able to provide forecasts of clinical activity in the following 2 weeks. We were also able to help inform policy levers that were already being in place or being enacted to increase staffing capacity. So that's in gold, or occupancy in purple, with preserved or additional beds. So an example of an internal policy lever was ramping down of peri-ops, which moved staff to PICU and enabled the PICU to preserve some capacity. An example of a regional lever was for other hospitals in the Champlain region with pediatric beds to increase capacity. And an example of a provincial lever were these directives to move older youth to adult ICUs or transfer them out to adult hospitals. We also took a step back after the IMT was folded to see how well we could have predicted the surge volumes back at the beginning of September, given the exact number of influenza and RSV admissions we had during the surge. It's just like the model validation that I showed earlier, except now data were held out after September 4th, and instead of the end of November, like you would have seen in earlier slides. So it's interesting to see what we could have predicted given precise viral numbers and what we could not have predicted. For example, we could have predicted the surge in inpatient and ED volumes very well within 1 standard deviation. So again, blue is actual data, orange are predicted data, even though this model did not take into account the expanded number of beds available to inpatient medicine for admissions and the staffing shortages that may have been faced in these clinical areas. So, you know, we may find it challenging still to use the forecasting model to plan for the number of beds that we will require, but we can use the model to look for the worst case scenario in uncertain situations and plan the staffing and bed capacity piece, knowing the potential direction and intensity of the viral surge. As noted before, we could not have predicted PICU volumes very well, given the exact RSV and influenza predictions. And this may be because the model did not take into consideration the staffing shortages there and real-time decisions about where higher acuity patients would receive care at CHEO, like in the PICU versus inpatient units as level 2, and the distributive model of care among PICUs in the province, which may have resulted in CHEO taking on a lot more patients earlier in the surge versus, so like here, versus fewer in the holiday period. So this is, I think, worth exploring. Then this begs the question of what next? So we've got data, we have thoughts about plans. How do we face and blunt the next surge situation? And you know, we've been looking. So our group has been looking at establishing a hospital-based surveillance program. This is certainly not just within our group. In speaking with various stakeholders, there is a really strong precedence of the benefits of hospital-based surveillance programs. But really, you know, the goal for this one would be, can intensity and duration of surge be predicted early on? The corollary is, can service closures and staffing shortages be avoided to meet the increased bed demand? We have to anticipate future waves of respiratory viral activity and not establish these surveillance programs de novo during times of crisis. We've already been in that place where we've taken up every single bed space in our PICU and have nowhere else to move our kids into a level 3 space, and have had to create additional spaces on inpatient medicine and outside of the ED for kids with potentially higher level of acuity, care acuity. If CHEO was a canary in the Ontario coal mine this time, we need to ensure we have capacity across the pediatric health system to allow for rapid and coordinated responses to community level outbreaks. And beyond the outbreak response, there is good evidence of hospital networks having been established to provide quality data for IPAC and immunization programs, so we can learn from them. But even before the activity surge in the hospital, I think we're learning about potential for out-of-hospital signals that can act as early warning of increasing bed demands. And we saw this with earlier in the pandemic with wastewater levels following, giving a good sense of what was to come with COVID-related admissions, especially in the adult hospitals. So we also looked at wastewater data. And what we saw was that influenza-related admissions at CHEO essentially overlapped with regional wastewater data, influenza data, with less than a week of lead time. That's really not helpful in terms of standing up additional, creating additional capacity to meet the anticipated demand, whether it's available beds or staffing. The associations between RSV and admissions, between RSV admissions and wastewater signals are less clear, but they're currently being worked out given the initial linkage and then decoupling of the signals. And we're comparing our data with Mac Kids in Hamilton to better understand trends and see if it can act as out of hospital early warning signal. We also looked at test positivity across the IRLA lab system. So when we looked back at test positivity data from IRLA since last September, we saw that regional data, which again includes adult hospitals as well as CHEO, are a close proxy of CHEO data with minimal lead time, which actually makes sense as triplex testing is primarily performed among people requiring admission. And CHEO contributed 90% of the testing volumes early in the surge. So this is tracking very closely to our admission data, appropriately so. We've heard over the years about Australia's influenza season as sentinel for what's to come in the Northern Hemisphere. And it begged the question of whether even the recent experience in Australia, whether that can act as sentinel for our surveillance season. And it's an interesting case study with important similarities this season related to ours. So the 2022 influenza season there began earlier. It was a shorter season with a larger peak. They had more than half of their hospitalizations in kids less than 16 years. And it was predominantly driven by influenza A. Interestingly, they had their winter break in the downturn of their season similar to ours, and did not see resurgence following the winter break. And finally, we had comparable durations of peak flu and of peak influenza season periods, with about 14 weeks in Australia compared to Canada as well as in Ontario. So I wanted to leave time for questions, but some takeaways from this discussion is that we saw a progression of respiratory viral activity among children in our region that was earlier, with a steeper increase and higher volumes compared to pre-pandemic years. While acuity was proportionately similar to previous years, the larger volumes of children requiring resource-intensive care resulted in policies to increase occupancy and staffing at local, regional, and provincial levels, which we have all acknowledged were disruptive, but necessary to have these additional volumes managed. And surveillance systems and forecasting modeling warrant further study to reduce mismatch in bed capacity to bed demand, and towards goals of improving patient flow, corresponding clinical staffing requirements, and key performance indicator, which will include adverse events and staff and medical staff satisfaction and family-centered care. I want to acknowledge the frontline clinicians and the staff and operations who supported them to provide safe and quality care through this period. the forecasting team who spent hours every week preparing and reviewing the data to be presented to IMT, the CHEO BI team who got us the data in the first place and worked hard with us to ensure that we had our data distilled down to the clearest detail, and the CHEO incident management team. I'd be happy to take questions.
All right, thank you, Nisha, for a fantastic presentation. So much data and so much really helpful interpretation and guidance about that data and how we use that data. And thank you for leaving us lots of time for questions and discussion. So if anyone has any questions for Nisha or comments, please go ahead and put your hand up, or just start to unmute yourself and just start talking. The big question, of course, Nisha, is what's going to happen this fall? I think what you showed us in the graph certainly demonstrated what it felt like through that period, especially some of those sharp peaks. But yeah, what's going to happen? You don't have to answer that question, but that is a big question.
That's also why I look to what's happening in Australia.
Yes, exactly. Okay, we have a couple questions. First from Natalie Major, and then Dare McNally. Go ahead, Natalie. You're muted, yeah.
Thank you. Nisha, fantastic work. Congratulations, really appreciate you driving and presenting this information. I also want to say a big kudos and thank you to the organization for the creation of the IMT and committee, as this has been instrumental in overcoming the challenges of this surge of patient. I know that you've mentioned that you're not looking at staffing, but one of the question I have is actually around, we are in an area where population is increasing. And in my mind, there's going to be more infection. The infection rate is going to, increase likely because there's more exposure. We have increasing population of children. And, what are other areas, either in the province or in the country or other countries, that have looked at a model to ensure proper physician staffing for responding to those acute surge, or process models? Is there such information coming out? Because really our organization mobilized physicians from all area of the organization to be able to meet the demand of care delivery. And we should have an opportunity to look at other intervention. So
I think your question is so important because I think every year that we face these viral surge periods, we leverage one service to increase capacity in another service. And we want to get away from that, and we should get away from that, especially as we see backlogs of care increasing in other services in the hospital. I have to say that the models that I've looked at have been pretty limited to volumes, and there have been some consideration of staffing, but I think this is an area that needs to be explored further. We were really pragmatic and crisp based on the timelines that we had to stick to EPIC data. I don't have insight into how staffing is captured here, how medical staffing is captured here. And I think ideally we would want to have inputs that are easy to incorporate into the model, and that can be and that the model can learn from those changes in inputs, right? Like that's, I think, where you're getting to. And I know that there are people here who may be able to speak to those principles and methodologies better, but that's certainly an area of interest moving forward, especially now that we've been able to harness our EPIC side clearly. But I actually don't even know if we have a place where our data go in easily around staffing to be able to incorporate it into the model. A great, really good and important question.
Thank you. Dare McNally, go ahead, Dare.
Thanks, Mona. Thanks, Nisha. Great talk. I was curious about your thoughts. You can answer, this is like a choose your own adventure. You can pick one of these two to answer, but curious looking forward as it relates to RSV, what do you think the next couple of years will look like with respect to the new vaccines and how that will impact things, or avian influenza. So choose your own adventure.
Okay, so you've like touched a nerve for both of them because I think if I have to choose, I'll stay away from avian influenza because I feel like I'm still too closely linked to people's frustrations around COVID and the emergence of this novel coronavirus and all the policies that we had to put forward. But avian influenza is certainly a real threat. It's becoming a more and more real threat. But with RSV vaccines, I think it's really going to change the dynamic if the uptake is good, right? It really depends on the uptake of the vaccine among adult populations, and because that's initially where it's going to be focused, right, on people who are pregnant and providing cocooning protection to the newborn and the infant. I also don't know, based on our experience here and the Danish experience, whether we're going to be shifting our RSV disease to an older population, because we were seeing more older kids, like 2 to 4 year olds, requiring admission for RSV, whereas that was pretty unusual in previous time. I would welcome anyone's collaboration on parsing through our data set to get a better sense of whether we saw, whether there were aspects of the older patient population that, risk factors that may be able to predict what it would look like in the future. But with the RSV vaccines, I think we have to be open to either seeing a blunting of future surges or a shifting in the demographic of kids requiring admission for severe RSV disease. What do you think? You're like the RSV guru. I wonder if that was a trick question.
Not about me today. It's about you.
We'll bring Dare back another time.
Yeah, we'll
That's
talk
great.
about
Thank you.
Thank you for joining the collaborative effort.
Now I have another question about avian influenza. No, I'm joking. Okay, off you go.
Okay.
All right. Next question to Nicole. So go ahead, Nicole.
Hello, thanks Nisha for a nice presentation. I have a couple of questions, and so first of all, the model was really nice to see, but as you mentioned, it was difficult to predict the acuity of care, so the PICU, if I understood that correctly. And so my question is, what proportion of that do you think was due to RSV, and what proportion was due to influenza? So that's one part of the question. And then the other part of the question is what you thought the contribution was, or what the reason for this was. Was it because of delayed care, so the acuity was higher, people came in a lot sicker? Was it? And then the next part, which this is the last comment, is overlaying the vaccination rates for children for influenza, and whether we should be shifting our public health approach to say if 80% of the children, depending on the efficacy of the influenza vaccine, get vaccinated, this is our model. So overlaying that kind of modifiable behavior to these kind of models. Sorry, a lot of questions.
No, these are great. This is why I wanted to give time to hear your thoughts as well. So I have to tell you that I don't have the data up front about the PICU proportions of RSV and relative contributions of RSV and influenza in the PICU, but I can get that, and I'll be able to share that with you. I think the question around did people come in sicker is a really important one, and we're actually reviewing that now. So we're going back and seeing among those kids who were admitted level 2 or level 3, and how many. I think we have to parameterize how we're going to define coming in sicker. So is it all the kids who are, just admitted level 2 versus level 3? And not, whether it's a transfer or it's a new admission, or are we talking about kids who had multiple ED visits in the time leading up to the admission? So we're looking at all of those variables. So I'll be able to, because that's an important balancing measure, right? Like in all of our communications internally and externally, and telling people like, don't come to the ED when you're well, like come when you're sick. Do people end up coming in sicker, or because of the lack of availability of beds, do the ED teams have to mitigate risks, right, in real time and provide guidance to families, and then have them come back when they were sicker? I would love to look at vaccination rates in these models. These are not publicly reported, and it makes it problematic, and we do not consistently look for them in our, we do not consistently ask for them in our admissions. We're pretty good. Like on the MedRec, it'll say whether a patient admitted with COVID-19 related illness has had the COVID-19 vaccine, but that hasn't distilled out to other vaccine preventable diseases.
Yeah.
So unless you're the discerning clinician who writes down immunizations, in that admission or progress note when you've got the results, it's impossible for us to pull those data out automatically or easily and put it into the model. But I think it's so hugely important.
Yeah, and even the use of oseltamivir, which is kind of like magic. And, in the previous several years ago, it was we had influenza a couple of years ago, that med reconciliation always included influenza vaccine. And for some reason, because of COVID and stuff, I understand, it's been kind of fallen by the wayside, but that might be something really interesting. Thanks very much. I appreciate it.
Yeah, no problem. And I'll also say that, when our ID group, was pretty sensitive to this, there was communication coming out from different pediatric centers and public health groups, like promoting the COVID vaccine in the midst of the surge. And our ID group was like, where's the flu vaccine in all of this discussion? Like we have years of knowing that this works, that this helps to blunt hospitalizations. And we're having a challenge with more sick kids presenting to the hospital, like higher volumes. Like this is the time to put out that message. And so I take your point, Nicole. Thank you.
Great, thank you. That's particularly resonated for me, because I do ask all the patients that I see, regardless of what they come in for, whether they had their vaccines, all their vaccines, and it was so uncommon for parents to say yes, that there was an influenza vaccine. They kind of looked at me like, oh, we already got the COVID vaccine. So there was a big disconnect. And when you look at that huge peak in influenza that we experienced, it's not a big surprise. There was a comment in the chat, Nisha, and then we'll go to Joff Shafson. There's a comment from one of our merge physicians, Mel Bichard. CTAS scores to identify higher acuity / sicker kids might be more sensitive than admission rates or levels 1 to 3. Any thoughts about that?
Thank you. That's helpful. This is where I welcome the expert input and insights from others to help to refine and strengthen the model. Thanks, Mel.
Okay. Great. And then over to you, Josh.
Yeah, so just more a comment. So this we've talked a lot about this data, and I think it's really exciting. I especially love the fact that the prediction in the PICU did not match the actual, because you anticipated that we would have too many people, and so you purposefully got rid of it. So I think that that's a major success in using the forecasting data to help support function and care of patients. So really, really nice. Just one thought now, of course, I forgot my question. Anyway, that'll be my comment. Oh, I think the other thing that's very interesting is, so when the public sees surge, they ask, is this a new aggressive bug, a new superbug, et cetera? And I think your data shows very nicely that it's not. It's the viruses that we know. Why we have such high levels can't explain, but you can speculate all you want about people's immune systems and getting sick, et cetera. But in the end, this was about volume and capacity and the ability to skillfully care for children, rather than RSV morphing into something terrifying. So I don't know if you want to comment on that, but I was just really struck by that data.
Yeah, thanks. Thanks for commenting on that, Josh, because I have to say that as we were seeing the data unfold, it was very reassuring early on to look at those lack of differences in proportions of clinical severity or acuity, to be able to use that as a proxy for not like as a proxy of virus, aggressive virus. I'm missing the virulence. There you go, of the current pathogens that were out there. So, but I'm also mindful that like not everyone was seeing these data, and you know I have to wonder, you know, just going off a bit on a tangent, how useful it would have been to see these graphs as the situation was unfolding. I mean, it's a bit of a question to Mona, but it's also a question to our department, you know, where we just so much in the thick of it that it was like, not one more email, not one more data point. I just need to get through this shift. I have to say, when we put out the initial data, I was pretty agnostic. Like I didn't know what to think about the exceptionality of the period because I happened to not be on service at the time. But when I saw the volumes and the uptick and the ongoing uptick of our test positivities early on, I signed up for shifts like that. I mean, that was sort of my response, and I was yeah, it really helped me to understand a little bit of the challenges that our colleagues were facing.
Great. Thank you. Question to, okay, Chris Badabunker, and then there's one question in the chat. So go ahead, Chris.
Sure. I'm sorry, for
the
some
last
reason
one.
I can't turn my video on. Nisha, this may be beyond what you can answer, but there were a lot of us providing care outside of what we normally provide. Were you aware of any problems with the care provided, like kids who were sent home too early and bounced back, or care in the emergency that provided by, you know, non-usual physicians that, you know, was a problem?
I think it's really, really important that we not only look at the successes of our work in getting kids in, but balancing measures to ensure that we weren't compromising quality of care, or that we didn't have any consequences to these decisions that negatively impacted patients. We're working through that now, Chris, like looking at those ED visits relative to hospital admissions. I have to say we're not looking at it at the staff specialty level. So we're not looking to see if these were kids who would have been admitted to pediatric medicine docs versus ID docs versus palliative care docs or surgeons. We're looking at it more at a systems level. And I don't know that I would want to drill down to that specialty level, but I'd welcome other thoughts about it. Mm-hmm.
Okay. I will say, I think Chris was maybe referring to because of the surge support program we put in place, that we had physicians from across CHEO actually supporting the surge, but the emerge patients seen in emerge were all seen by emerge, the regular emerge physician staff. So that there was no change there. It was the admitted patients. Yeah, from what we could see living it in real time, you know, that the patients were very well cared for. We had lots of good, good systems in place. Yeah, go ahead.
And I should point out that so to Chris's point, we have been, so the hospital has been tracking patient satisfaction questionnaires. They've been getting feedback that's been overwhelmingly positive from caregivers and patient family members. And you know, with my IPAC hat on, I've been looking at healthcare associated infections as a balancing measure because of all the cohorting that we had to do, unconventional cohorting that was specific to this surge period and related to our increased turnaround time with test results. But and so anyways, in terms of visits or return to ED. We're looking at that now. I'm not able to say anything, but it's reassuring to hear from Mona. The general gestalt from the ED folks was that there weren't kids who were coming back, that there wasn't a big flag of kids who were coming back from having been cared for by colleagues elsewhere in the hospital.
All right, thank you so much, Nisha, for a fantastic presentation. We'll have to leave the last question for you to consider over the year while we're waiting for that next surge to happen, because it probably will. We have to be prepared, and that really speaks to the importance of the work that you have been doing, and hopefully will continue to do in future. So thank you again for a fantastic presentation and for all that you've been doing to support us through COVID all these years. Thank you.
Thank you.
Have a wonderful day, everyone.
Have a nice day.